a lot of times people ask, why do you actually need to train anybody to do this? I mean, it seems, just tell everybody to be nice to each other and ask how they're doing. And there is some truth in that, informal peer support is really important too. So we're not saying, only fully trained peer supporters should talk to their colleagues. But I will say that asking someone to do peer support, a physician or a nurse, is asking us to do something that we are not used to doing, and that is to be able to sit with someone else's pain. We are usually, if someone comes to us for something, we want to fix them. That's my job as a surgeon. You have a problem, I don't, say to you, well, which approach do you think, I should use to take care of that growth? I mean, of course, we're doing things in partnership, but mainly we are there. People come to us to fix their problems, and this is not a fix-it situation. On the other hand, being listened to very deeply and directly by a colleague who understands what it feels like to have this burden of having harmed somebody, or even just seeing something emotionally stressful in medicine, is so helpful and so healing in and of itself. So what we have to do in the training is we have to teach people, physicians and other clinicians, to listen without the goal of fixing. And that actually takes some work to do, and we do a lot of role play, as you know, Brian, in the training. And then I think the other thing is that unlike psychotherapy, where I think psychotherapists are extremely well trained to listen, this actually, in addition, requires some sharing. So if I'm peer supporting you and all I do is, nod and say, wow, that sounds incredibly horrible, and you're thinking, well, gosh, she maybe has never felt this. It's part of our training of the peer supporters to share to some degree. I don't know how you're feeling exactly, but after I made an error that I think of all the time when we talk about peer support, I felt pretty awful. I kept going over and over the event in my mind. Is that something that's happening with you? So being able to give of yourself, but not too much, and also to listen, but not just listen. And the other thing is that we tend to, and because we're trained to, be very judgmental and rigorous about listening to things that happened in healthcare and wanting to make them better. And so there's a part of us that wants to critique the care. And that absolutely is, we train the peer supporters, it's not a critique situation. That should absolutely happen, but that would be in a different forum, in morbidity and mortality conference, a quality conference, what have you, but not in peer support. We're not there to critique. And it's why some of our peer supporters are, and I've done a lot of individual peer support, I may be peer supporting someone completely outside of my specialty. In fact, most of the times I am. I don't have a right to, or the experience or expertise to critique the actual event. So I think that's an important part of training as well. So the other caution is that not everybody does want to or need to talk about an event. And to push somebody to do it is also wrong. And so that's part of the training, again, as Brian and you know quite well, it's an offer. We make it easy, so we don't say we're here and call us if you need us. But so it's an outreach, but it's an invitation, and there is absolutely nothing wrong with 50% or whatever the percent of people are saying, thanks anyway, I'm good, it's okay. So I think that's important. And the very last thing that I wanted to say, just in response to what you were saying, Brian, is, which you alluded to, is we're not really asking or wanting clinicians not to feel, not to have these emotions. It is absolutely that's what being human is. If you care about somebody, a patient, which we all do care about our patients, of course it will hurt if bad things happen to the patients, especially if you had a hand in that. It's more a matter of managing the emotions. So first of all, you can heal, and second of all, so you can be there for the patient and family.
Thank you, Jo. And that's really, you are a national leader in peer support programs, and you've shared previously with us and how your program has evolved over time. Can you share with our audience some of the challenges that you faced, some of the considerations for future growth and sustainability of peer support programs?
Sure, I'd be happy to. We always want to share our successes and our failures too, so I'm happy to do that because we're all learning. You know, nobody really has any proof of what's the best way to go about building resilience and facilitating recovery after emotionally stressful events. But we do know from trauma literature that there is a reason to believe that this would be helpful, and then we have the studies supporting that it's what clinicians want. So I think one thing that's been helpful, I'll say on a positive side for us, is just really the rock-steady institutional support that our leaders really recognize this is important. And to really run a program, I mean, it's not wildly expensive, but you can't just hope everything is done with volunteer work and no structure, no organization, no administrative support. So I think we have learned that, in fact, because it did start out as all volunteer, and eventually we said we need some support, and they've been great about doing that. So, and I know that you have that institutional support as well. The other question was, well, who should be a peer supporter? And we started out with volunteers. You know, I'd like to do that. And the problem with that is a couple things. One is that the desire to do something is great. Of course, it's necessary, but it's really not sufficient in understanding whether you'd actually be good at doing it or not. So there are two things that we found people wanted from a peer supporter. One is they needed the person to have some credibility in terms of their clinical expertise, not even in their specialty, as I said, but just knowing that is a clinician in good standing. Because, you know, if you're going to support me and I know that, you know, maybe you aren't the person I'd respect clinically. And this sounds awfully harsh, and I don't mean it to be, but there have to be clinicians who really get it and who are, you know, active clinically in some way or have been and have a reputation for being good clinicians. And the other thing is it requires a degree of relational skill that's pretty high for the reasons I said before. And so what we did was we went from volunteers to actually going to the departments with the support of their chair or chief and saying, we're going to send out this email describing the peer support program, and then ask nominations from the faculty and residents. Who would you want to support you in an emotionally stressful event such as an error? And so they're all peer nominated peer supporters, and that really made a difference. So that's been very helpful. I think where we are not doing as well as we want is, how do we know somebody needs support? Well, first of all, we're not waiting till people are suffering. So our premise is we're going to support anybody involved in a potentially emotionally stressful event. And so if we're not hearing about those events, then how do we know to go and reach out? And I think we know in our institution, and it's not like we've studied this, but we just know it from empiric data and other studies, that there are things that happen that don't get reported. So how do we know about that, and also encourage reporting more, which is really important in being a learning organization. So we're trying to work on that. And the other question is, do you support how do you assign the peer supporter? And does it need to be someone in the specialty of the peer? And our conclusion has been, and just from really our practicing this for several years, is it doesn't necessarily have to be a match that way. We do think that if the injury or the trauma, if you will, or the error or the event is an interventional one, then it's probably important to pair the peer with an interventionalist. It doesn't have to be in his or her specialty, because making an interventional injury it feels very, just in some way different. And so that's been helpful. And the other thing is we don't assign a junior peer supporter to a senior peer just because of that sense of, you know, you want someone with your level of experience anyway to be peer supporting you. The other question is follow-up. What we've trained, and I'd be curious to hear what you do at Stanford now, is we've trained to the peer supporters to have this be an intervention that has one follow-up call at least. Is it okay if I get back to you in a week or so and check on you? You know, asking permission. But we don't do ongoing peer support. What we do is if somebody feels that he or she really is not, you know, recovering in the way that seems okay, that this event is interfering with their work or their home life, or in any way they feel they need more support, our job as peer supporters is to connect them with resources. And so we see ourselves as connectors because it seems to be more acceptable if you recommend to me, Brian, that, Joe, hey, it sounds like you're still suffering. I have the name of a psychiatrist. We do have those on our team, if you will, ready to be available, or someone in EAP, rather than I have to identify myself as having, a problem that needs psychiatric help. So just getting over that barrier. But we're not really sure, is that right? Is just one follow-up intervention enough? So I do wonder about that. We're holding that as a question. And the other is peer support is hard. In some way, it's really rewarding. Brian mentioned that. It just feels so good because people are quite appreciative. They, thank you so much for calling. This was helpful. But still, we're holding other people's sadness and stress. And so we believe firmly that we need to support the supporters. So we do have quarterly meetings. We also have a way they can call me as head of the program if they have issues, questions. And I have had peer supporters feel in a quandary about a certain peer support and how it went, or maybe somebody needed further help and they wanted to help me guide them. And then how do you assess the program? We've been a little reluctant to interview those peers who we've supported because of the sense of we don't want to, re-traumatize them or invade their privacy. But I think we're far enough out years-wise that we're going to, well, I know we are, that we're going to do a study to really look in more in-depth qualitatively of what was helpful, what wasn't, were we there, weren't we there, and in what way. And I think the other point is that we've really now integrated the peer support program into our disclosure coaching program. So we found that there are a lot of times when the conversation, the planned conversation with a patient and family, which may, once we discover something has gone wrong, may not be for weeks after we've interacted with the patient. We found that is a moment where, first of all, disclosure coaching is helpful, where we can help the clinician, in conjunction with risk management, plan how to speak to the family, but helping the clinician identify what emotions he or she is feeling so that those emotions don't go into the room virtually with the patient.